We have 4 folks on the reactor panel who come from a variety of different perspectives, but can all speak to the challenges with making the safety net work on the ground in the community day in and day out. And I'll start with David Scher. Again, all of their information is in your packet, so I'm just going to be very brief right now. David Scher is described, I think, on the agenda as an Executive Medical Director of Blue Cross and Blue Shield of Michigan, which he is, but for this panel perhaps is better known as the Medical Director of the Corner Health Center in Ypsilanti, Michigan. He's been there for many years. I think was really the founding medical director there, working with the adolescent population. And the Corner, for those of you who don't know it, is a hybrid model as defined by Peter. Next to David is Vern Davis Anthony. Vern is the CEO of the Greater Detroit Area Health Council. She has a long background in working in community-based care. She was also the director of the Department of Public Health in Wayne County at St. John's Health System. So she has a wide range of experiences in this area and is currently heading the largest coalition, the only one really in Southeast Michigan, that represents multi-stakeholders to deal with these community-based issues. Next to Vern is Debra Riddick. Debra is a JD also, but also a nurse, and a nice combination and an unusual combination. Debra is head of the school-based health center group in Michigan and has a lot of experience and background to present to us on the school-based health centers, which we really haven't talked about so far as part of that safety net, but a very important part of the safety net for many children and families as well. And next to Debra is Kim Silbisky. Kim is the head of the Michigan Primary Care Association and also has run federally qualified health centers, has been a national voice in support for federally qualified health centers, has had a long leadership role in our state in really understanding and strengthening the network of federally qualified health centers. So we're delighted to have you all here. And we're just going to go in order. So we'll start with David. We've asked them to do about 5 to 7 minutes of comments reacting to what they heard earlier from the discussion and from the presenters. So go ahead, David.
Okay. Thank you. So appreciate the opportunity to speak with you. So I'm very excited about the changes that are afoot with healthcare reform as a result of the recent legislation, and I'm sort of not listening to the radio when people are talking about Republicans wanting to gut it. A concern, and I'm especially excited because my patients, like those other caregivers here, providers of healthcare who serve people who are underinsured or uninsured, are going to have many more of our patients covered as a result, and that's quite exciting. So expansion of Medicaid, that's a great thing. At least for a couple of years, we hope to see better payments for Medicaid services. That's a great thing. Though I'm not entirely excited about everything, and I'd like to share a couple of concerns and then a few thoughts about what the future holds. Sort of where the safety net community ought to be heading and thinking in terms of its own evolution. So one concern I have is that when I listen to folks from inside the Beltway or policy experts who advise those inside the Beltway, they have a kind of, I hate to say this, but it's a true observation, self-satisfied and somewhat narrow perspective. And they tend to think that they can prescribe through legislation and regulation what folks ought to do in order to make it all right. And I think they tend to paint with too broad a brush. So the dialogue about FQHCs and community health centers and hybrids and free clinics, I think reflects a little bit about that because of the way it's sort of codified in legislation and the way people talk about it. There is this tendency to think of FQHCs as the answer, and that as we work towards more systems of care, systematized health care, that FQHCs are really the only ones that are going to be able to, in the safety net community, to rise to that challenge and that level of sophistication. And so the language even, I think, is problematic because as far as I'm concerned, there's this remarkable diversity in the communities across this country in the way the safety net is structured, organized, what animates and enlivens it. And some communities have really strong FQHC programs, and some don't, like Brent mentioned, have any at all. And I tend to think we should be speaking of community health centers as the frame of reference. Some are federally qualified or federally reimbursed, and some are not. the whole term hybrid sort of is it's problematic to me, because what is a hybrid? Is that a car, or is that a community health center that's not getting money from the Fed? So I'd rather we talk about and support communities in creating health centers that are part of a whole cloth of a safety net that really works best to meet the needs identified by the particular community. And there are other niche types of providers that have to be considered. Brent mentioned the Delanis shelter, which is for homeless folks in this community. That's not an FQHC, never going to be an FQHC by itself. School-based and school-linked health centers, certain mental health and substance abuse niche population service providers that aren't part of the county mental health system. And so we don't want to paint with such a broad brush that these sort of get painted out of the system. This week I saw a young man, a teenager, with asthma with his grandmother, and she was almost in tears because they couldn't afford the controller medicines that would help him get his asthma attack under control. It happened that I had one last inhaler that I could give him, a steroid inhaler, and so that was a blessing. But in a reformed health system, he'll be able to get Medicaid, he'll be able to get medicines, and this will be a good thing. Same day, I saw a young man from Mexico whose father was deported. He's working construction, this 16-year-old, just to be able to survive. He wants to go to school, couldn't afford medicines now, certainly won't be able to afford medicines in the future within the current political climate if it's sustained, where nobody wants to pay for people who are undocumented and illegally here, even though they're working hard and contributing to the society. So I think there's some big gaps in the Healthcare Reform Act that we're not talking about. So the Washtenaw Health Plan was mentioned. It's one of the, 33 or so county health plans in the state of Michigan. An essential aspect of the safety net in our community binds some of the safety net clinics together, helps support them in many ways, offers an access point for people who are underinsured and uninsured to gain access to primary care and specialty care. It depends on DSH payments, disproportionate share payments. Healthcare reform, because we're going to magically take care of the uninsured problem, is going to eliminate those payments. And so that'll create a sucking sound in counties around Michigan with regard to the resources available to support these county health plans for indigents like my young Mexican client, who will never be eligible, at least in the for reasonably foreseeable future, for Medicaid, unless he becomes pregnant, and then he can get emergency Medicaid. So the changes afoot are good, but they're not completely adequate. So in the remaining couple of minutes, I'd like to switch gears. There's been talk about the medical home model, and I would say that while safety net clinics invariably do have more or less strength in this arena, I think they sort of helped create the model and have done so over the last 30 years or so, 30 or 40 years really, with multidisciplinary team-based care addressing a totality of patient need in a pretty organized way when they have the resources to do so. So that's all great. I think that as the healthcare system evolves, they will be called upon to become more well-defined, more sophisticated medical home-based practices. And so they're going to need systems of care that include sophisticated information systems that they can use to share clinical information, as we've been talking about today, with other entities in the safety net, with hospitals, with nursing homes, with homeless shelters, and with the public health system. So there's a long way to go there, lots of investments, lots of challenge. Also processes of care, we talked a lot about that, I won't belabor that, but care management I think is the cornerstone for that. More sophisticated, more reliable, proactive systems based on clinical registries, integrated not just within the practice, the safety net provider, but across practices between specialist and primary care, hospital, other facility stakeholders. So we move from independent to interdependent to truly integrated systems. That doesn't mean that anybody has to own the safety net clinic. That doesn't mean, and it's not a bad thing you do this, but it doesn't mean that safety net programs have to give up their identities. They can affiliate with their sister agencies and the bigger, more established mainstream systems to create comprehensive systems that will be then eligible to participate in an accountable care organization approach. In Michigan, in the Blues, we're calling this organized systems of care, not accountable care organizations, because we're more worried about the systematization of care, and fundamentally, we want to call out the purpose. The purpose of these OSCs or ACOs is not to save money, although that's necessary for if the health system is going to survive. The purpose is to move back more towards population well-being as a primary goal, and social wellness as a primary goal, and patient-centeredness as a primary goal. And so we need to be keeping those purposes in mind, not just thinking, how do we help the institutions survive in a changing system? And then one last comment. We talk a lot about the safety net community and the Medicaid provider community and what we can do to help them. And I hear this sort of inside the Beltway talk, and I've participated in some dialogue about this, and it's, what can we do to help Medicaid providers become medical homes or organized systems? And while that's all good, and people who have a predominance of Medicaid clients in their practice need that kind of help, let's step back a moment. This isn't about Medicaid or Medicare or uninsured. It's about the community. And so systems of care have to be grounded in community, and they should be unified. And so it shouldn't be, what's the Medicaid system doing, or what's the uninsured system doing, or what's the safety net system doing? It should be, how does that fit into the whole cloth of a healthcare system, so that then the deeper pockets among us, the universities and St. Joe's in our community, in Ann Arbor, Ypsilanti, Washtenaw, Greater Washtenaw, for example, are helping to support and integrate with the safety net. So I'll stop there and say thank you.
Good afternoon. I'm, as was said, Vern Davis Anthony from the Greater Detroit Area Health Council. And for those of you that don't know, the GDAC, as we call it, is a regional coalition, Southeast Michigan, working with the 7 counties with the mission of addressing health care issues related to cost, quality, and access to care. And we are multi-stakeholder, meaning we bring all of the parties that are interested in health care. That would be our purchasers, health plans, physician leaders, community organizations, including FQHCs, health departments, and health systems together to try and make some progress as a region on some of these very significant issues. And of course, access being key to our mission is something that we're very concerned about. And I want to thank Sarah, Peter, and Brent for their remarks. And I was taking so many notes, I kind of don't know where to begin since I only have 5 minutes, but I'll try. A few truisms of my own. I believe that PPACA, or the healthcare reform, is a step in the right direction. But it's only one step, and right now it's pretty far away. There's a lot of opportunities right here, right now, in Southeast Michigan and around the state that we need to get busy with. There's a lot to be done. There's a lot we know that needs to be done. And I think many of the aspects of the healthcare reform bill is simply giving us an opportunity to do some things that we know needed to be done. But it's also adding payment reform around that to help better incentivize that. But it's not a silver bullet. It's not a silver bullet. It's not a panacea. In fact, some things probably will be changed along the way in terms of the implementation, and that's okay. Also, healthcare access. It's not an insurance card. If everybody has an insurance card, then everybody has access. Well, we know the answer is no, because there has to be that safety net structure. And as Sarah said, everybody won't even have an insurance card. There will be a significant percentage of the population that will not have an insurance card. So the safety net is absolutely essential in terms of structures or places where people can go. Also, access does not necessarily mean quality or desired outcomes. We do have to say access to what? And what will be the outcomes. And the outcomes that we're seeing today is definitely not what we want to have more access to. We don't want to pay more to do the same things that we do, the way that we do them, and get the same outcomes that we have. So, our plate is really full. The safety net. The safety net in Southeast Michigan is, of course, includes the FQHCs, but it's also the health department clinics, the health systems. We have several very large health systems with large outpatient clinics that serve hundreds of people in terms of primary care. Emergency room, yes, the emergency room will still be important under healthcare reform. It will still be a part of the safety net. Free clinics, school-based clinics, and thank you to Dr. Brent for reminding us, Dr. Williams, of substance abuse and mental health. You know, that is the safety net. And I believe if we looked at Southeast Michigan, we would not be able to say that FQHCs is the single largest source of primary care in Southeast Michigan. I'm sure it's not, if we looked at the actual numbers and where people really went for primary care. And in terms of the uninsured and those that will be covered under healthcare reform, it really is not a homogeneous population. We have a very large number of working poor in Southeast Michigan. They go to various places for primary care, even though I would admit that many of those places would not meet the definition of a patient-centered medical home. But I can assure you they're all trying to work in order to meet that definition, thanks to the Blues and the other payers that are requiring that, certainly as well as Medicaid. And once that those uninsured that used to be insured, by the way, have new coverage, they'll probably want to continue to go to the providers that they go to. I don't think there will be a huge onslaught into FQHCs or clinics, just because that's not the history of the region. That capacity has not been there. I believe that many of those will continue to want to stay with their providers, and I think many of those providers will probably be out here competing for this population now that there's some quote-unquote money behind them. I know that most of our major players in Southeast Michigan are working very hard right now to be sure that they are in a position to be an accountable care organization, and that would be the physicians, that would be the health systems, physician groups coming together, people, you know, repositioning themselves just to do that. So I think that the competition, even for this population, will intensify in Southeast Michigan. In terms of federally qualified health centers, we have been underserved based on our designation, medically underserved, in Southeast Michigan, especially in Detroit. I think there's, 18? I have to look at Cynthia and ask her that, Cynthia Tagg in the audience, who's more of an expert than I am on actual FQHCs. There's 18 FQHC sites in Detroit, 21 in Wayne County, is that correct? Which, under anybody's definition, is not an adequate number for the population that we have. And we are in the business of trying to expand the FQHC network with new dollars. But I think I want to quote Peter when he said money is not enough. Just expanding more FQHCs definitely will not fix the problem. All the problems that you mentioned, Peter, we do have those problems. You know, there are issues of not having a system to really share best practices. There are issues in efficiencies. There's definite issues in being able to assure that continuity of care for specialty care within FQHCs, and it's not all the fault of a FQHC or a health system, but there definitely are issues there that must be addressed. So just expanding at the FQHC network will not solve the problem in Detroit, and we need to be aware of that. I really know, and I honestly believe that the structural changes, the systematic changes, the need for quality improvement, the need for transparency. I believe that uninsured people, just like all individuals, should have access to quality information. That should be public information. People need to make choices for the best care that they can get, and I believe that we need to provide those choices. One issue that we're all facing is a shortage of primary care providers. And when all these folks become insured in 2014 or whatever, that's not enough time to fix the primary care shortage problem. So we still have a problem with primary care. I do believe in the need to expand greater use of nurses and nurse practitioners and those models that I think are really more welcome in clinics, than in other practice settings. Peter mentioned regional strategies. Again, we must do that in Southeast Michigan. It is not just a Detroit problem. Our health systems are regional. People travel regionally for health care, and we need to begin to think of the safety net in terms of a regional solution. More integrated models, building on our health systems, and I think someone mentioned, I know St. John has FQHCs, Henry Ford. I think Beaumont just opened one up this week in Royal Oak. So this type of partnership really will have to be expanded. I don't want to close without mentioning leadership. That's one thing that we definitely need, and I would like to hear much more discussion about the population, less discussion about the structure. And Dr. Scher mentioned that it's like, will the FQHCs do this, or will this Medicaid providers or hospitals, and not enough discussion on the population or the people that we intend to serve, because some of these structures will have to change. And it looks like nobody really wants to change their structure. They want to be sure that their structure fits into the payment model so their structure can survive. Yeah. So we hear a lot of that, and that dialogue needs to change, but that's going to have to come from community leadership, not necessarily from providers, trying to, stay alive. Systematic measurement in terms of efficiency and outcome is key. I believe that whether it's an FQHC or a clinic or an outpatient clinic, we need that same measurement, and it needs to be something that the community recognizes and is aware of. And just in closing, I want to comment, Dr. Williams, on that special needs population that you mentioned. And Mary Ann did mention it earlier. I think we do need to begin to look at what type of structure will meet the needs of that population. Because if not only do we not serve them, we do a disservice to the others because of how we spend the dollars on that population now that really is not helping that population. But it's also taking away from the more general population that we can serve better if the attention wasn't, far, in one corner. And hopefully as we look at the structures under healthcare reform, there'll be some serious discussion on how to serve that population, probably not so much in a medical model, but more of a community model, with the medical system as partners. So I'm with you on that. And I just want to close my remarks again with just emphasizing that there's much work to be done now. There's much planning. There's much that we already know. We can just hear it from the questions, and I look forward to working with, the speakers, the University of Michigan, our community, and other folks in Southeast Michigan that are willing, to take some action now.
Thank you. As said, my name is Debra Riddick, and I'm the Policy and Planning Director for School Community Health Alliance of Michigan. We are a state-run membership organization that represents the school-based and school-linked health centers across the state. Currently, there are more than 90 school-based and school-linked health centers. More than half of them receive state funding as their primary source of maintaining the services. School-based health centers as a care model have been around since the late 70s, and in fact, Michigan got their first few centers in the 80s. So it's a model that's been around for a long time, and we've proliferated to the point where we are certainly a safety net, but in speaking of Wayne County, we also serve as infrastructure for the at-risk youth there. Nearly a third of all the school-based and school-linked health centers across the state are located and serving Wayne County residents and at-risk youth. So we certainly see ourselves as a component to the care here that's not going to go away. We are thrilled that we're invited to the table. We didn't make it to any of the slides, but this is certainly an exciting year for us. Next year. Yeah, because in fact, earlier this year in the CHIPRA legislation reauthorization, we finally got a definition. And then through great efforts through the legislative and congressional members from Michigan, school-based and school-linked health centers for the first time received both an authorization for designing and implementing school-based health centers, as well as some funding, $50 million through 2014 each year for improvements that could be used for, building structure, things like information technology and all of those things. So we're extremely, extremely excited about that. So when we talk about health reform and the implications for the model, which is school-based health centers, and I'll use that broadly, but it does include the school link centers, it's very important to understand that these centers are serving communities that are considered at risk. That means high rates of poverty, crime, certainly the food deserts and the physical exercise or complications, fragmented family structures, the crumbling education systems, you name it, these kids are impacted by it. So we are there helping to provide that piece of wholeness that keeps them together. These school-based health centers are, for the most part, physically in the school or between feeder schools. They provide complete comprehensive care, the wellness, the chronic care. And if you are going to impact, the long history, over time, you're going to have to impact kids, where they are. We're going where they are. So when we talk about things like access, it's built in. Kids have to attend school every day. They have to be there. So the nurse practitioners who primarily are taking care of them are managing not just their physical needs, but the psychosocial issues, as well as some of the other behavioral issues. Someone spoke to mental health, and unless you are in extreme need and you get a diagnosis that you're not treated, well, how much more so for children who are dealing with the social stresses that their parents or absentee parents have to deal with. So we have practitioners who are in place who are impacting them. They're learning about prevention, they're learning about wellness, they're learning about all of these other things that, again, if we're talking about a return on investment, this is where you should certainly start in order to build better healthcare consumers, in order to help them to understand about utilization and proper management. So we're really excited that for the first time, this model is getting the recognition so that not just in today's time, but generationally, we will see hopefully some outcomes that will receive improvements. Just to let you know what the need is for the model, when they did the grant appropriation for the 2008-2010 cycle with the state funding, we had over 100 applications of communities that could have qualified for grant funding. We had intended to do 18 grants, but sustained a state budget cut which only permitted us to fund 9 communities. So, and that would be in addition to the 90 centers that are running now. Some of the challenges that we have is because only the majority of our centers are state funded, there are outliers who are doing extremely good quality care that are privately funded, but unfortunately they don't have a relationship with us where we're able to get the data and information to build a stronger argument for all of the good work that we're doing. So that would certainly serve as one of our major challenges. We also talk about the fact that in the legislation that is health reform, we did get money for bricks and mortars. However, there was an appropriation to establish school-based health centers, which has yet to be appropriated. So we have no funding for hiring people and the regular administrative duties and the other things that the centers need. And so we are completely dependent upon state funding, which, as we know, in an economy such as Michigan's, creates a huge stress for us. We did sustain a 25% cut last budget cycle, which was maintained this year. Fortunately, through the executive office, we have a Medicaid waiver in place that allows us to draw down federal dollars because the majority of our patients are Medicaid patients. But again, that's a permissive role. With a new governor coming in, most certainly by Tuesday, that established relationship with our Medicaid office could leave. And so if, in fact, we're no longer to be able to see and pay for services to those Medicaid patients, then our model is truly threatened. And again, because it's an infrastructural issue, we're going to see thousands of students, and we see kids 5 through 21 at these centers who will have no place to go. Quite frankly, we have been serving as medical homes for these folks because no one's beating down the door for the low reimbursement rates to serve them. So if we can't afford to do that, you're going to have lots of kids on those rolls. The last study from the state for the state-funded center said that there were over 200,000 services for these kids that were done in that year alone. So we're talking about a huge deficit. So while we are really thankful for the federal funding, state funding is a huge issue for us. And so we are constantly on guard. You know, when you see all of the budget things that are going on up at the Capitol, we're involved in that mix, and we've been extremely, extremely successful and thankful for bipartisan support, because these centers are everywhere. You know, that the at-risk population for youth has grown, you know, by leaps and bounds just as a result of our economy. So there are many, many more communities who need these centers. When we talk about going back to federal reform and what it's going to do for us, we did have legislation in to try to get cost-based reimbursements like the federally qualified health centers. That went nowhere. That would have gone, you know, a long way to shore up and to make sure that we could have the services, because then we would not necessarily be dependent, or at least not as dependent to the extent that we are, on state funding. So that was something that is a challenge for us currently. We certainly agree with many of the other presenters today and reaction panel on the scope of practice laws. We are primarily run by nurse practitioners. The quality of care there, again, we would hold up against anybody's standards. Not only are they having to deal with the standards that the state establishes in order for them to receive state funding, but many of them are associated with health systems who have their own criteria for what is a quality measure. And so the care there is unique, it's special, it's definitely going to the needs of these young people. They see them every day. If we're talking about comparing that to a typical pediatrician's office where a child may see their pediatrician once a year, there is absolutely no comparison. The rapport is going to be there, the trust is going to be there. Just knowing that this is a bad day and you may come down to seem that you're sick when there's something else emotional or psychosocial or with your family going on. That's a connection you can't get in an annual pediatrician's office. So the outcomes for that trust measure, you know, are off the charts. And with that population, trust is everything. If you can't talk to a young person to get them to confide, there's no way you're going to impact their health outcomes. So for that reason, we really feel that scope of practice needs to be reevaluated so that these caring nurse practitioners can, in fact, do the things that they were trained and qualified to do. We also have challenges when it comes to the comprehensive data collection, because it's not consistent. We don't really have the numbers to speak to those folks who are privately funded, and we really wish we could reach out to them, and we hope to do so in the future. We talked a little bit about the health information technology and the medical health records. Very, very few of our centers are fortunate enough, obviously, because of our population base and the payment rates, to have that. But we are certainly excited that one of your speakers in the audience made a comment about a pilot project that's going on in Wayne County around the pediatric medical home model. We are excited to have been invited to that table, and hopefully it will be funded, because it will, in fact, be the first pediatric medical home model in the nation of its kind, which actually incorporates the network of school-based health centers as a part of that entire organization. So we're very excited about that. One last concern for me is on the issue of health equity and disparities. Certainly, as all of these initiatives go forward, because the population I serve are at-risk youth, many minorities, certainly all of them poor and impoverished, if in fact we continue to reward folks and health system models that already have the bells and whistles, and we exclude other types of care models, then that disparity and that health inequity will continue to grow and exacerbate. So I think that should certainly be a lasting thought.
This is a reactor panel, and I am the last member standing on the reactor panel. So I'm going to refer to myself as the amen member of the reactor panel, because everything I heard is true. Everything I heard is absolutely foursquare on the mark. I'm going to just run down a number of things that I reacted to like this. There are challenging patients, and they hit at least two of that list, Brent. At one time or another, we are all challenging patients. At one time or another, we all hit at least two of the elements on that list. Not all communities are medically underserved communities. Not all communities are challenging communities, but at this point in the evolution of, or the economic whatever of the state of Michigan, almost every community has challenged community members. And as of John, 2 weeks ago, Ian, Kim, Washtenaw County has been designated a medically underserved county. Having designated medically underserved community for Ann Arbor proper. Okay, I knew I'd get there sooner or later. This will no longer be the FQHC district. And we just recently had the opening of a health center, will very shortly, in Oakland County, in Royal Oak, as Vernice mentioned. This is not safety net at this point in time. What we're talking about is systems, elements that need to be complementary. Measurement is limited and not robust. Interoperability is not strong. Competition is a force that we deal with. There is a great lack of sharing of best practices. Fragmentation exists across systems, and I would even venture to say the term healthcare system is a misnomer. There is no system. There are systems within the environment, but there is no healthcare system. So, can we bridge this fragmentation? There is a requirement, as Sarah said, for clinical integration. There is a requirement for every type of integration if we are going to create system. And we need care management, we need that system, and health centers must be true to their mission of serving the uninsured. So, what I would like to do is just very briefly say, health centers are an asset. Health centers are a means of bringing comprehensive primary care, federal and state resources to communities. They are not competition, they are an asset in a community-based system of care. When we think about them versus us, I think we really need to think about that. Because I was reminded today when I spoke with the Free Clinics of Michigan, these are tax-funded assets. We're paying for them. So it comes to community leadership to determine how best to actualize that asset within your community. When you think about community health centers, they are community-led. We are all community leaders, and we all have a responsibility for being sure that that asset is complementary to all the assets that exist within that system. One of our greatest paucities at this point, my belief is in that leadership that Peter mentioned. In the leadership within health centers, I mean, they're all just human beings, right? They've got boards, community-based boards. You've got little, gray-haired ladies running $12 million budgets. They need your help. You are the community upon which they are based. You are the leaders who are their peers. You are the people who know what's going on in that community to which that health center should respond. It's a tremendous complementary model to other pieces of system that could all be woven together, but it's all of our responsibility to make it hum. Two pieces I want to talk very briefly about: quality. Peter didn't get to quality. Sarah referenced quality to some degree by virtue of the things that health centers have done. We are living under an embarrassment of riches in terms of the potential to develop quality systems right now. The trick is to get them aligned to the work that really needs to be done in order to report robust data, to utilize data to help to inform quality clinical services. We have the Regional Extension Center, which in Michigan is MCEDA. It's been somewhat controversial. It requires us all working together to be sure, once again, that we utilize an asset, a $19 million asset, to move us to where we need to be. Health centers have had an advantage in terms of some ARA dollars, in terms of Institute for Healthcare Improvements collaboratives that allowed health centers to build some behaviors in reporting. But Peter, we're not there yet. And health centers have a long way to go. So we need to utilize those resources that we have to help to get us there. I want to let David know, and the folks at Blue Cross, how important the PEDIATRIC project has been to us, to our health centers, to one, allow our health centers to demonstrate that they're pretty darn good, but to allow our health centers to understand they aren't all there yet. But the alignment of the payers around this quality work, this is exciting. This is lions and lambs laying down together. And if we truly can get these resources to align, drop some of our institutional oochiness, that's a technical term, and begin to really get this stuff working, I think we have a possibility of improving the quality of the health of the state, improving the efficiency and cost effectiveness and return on investment. And those resources are there today, and we need to get them working. Secondly, alignment. Once again, Brent, we don't have to wait. We need to align. Some very exciting work has been done, and Lee Green was here. He is with University of Michigan. He is a researcher. He is CTSA, translation of research to practice, working deeply with health centers around the state. That resource has helped in the quality, in the EHR development, in many, many ways, and that's just one of many, many examples. But to align the resource that is free clinics with the work that is community health centers, align the health systems work with the work that we're doing, and that alignment is happening in many ways. I hope ACOs enhance that. As David mentioned, they refer to theirs as organized systems of care under the Blues. Michigan Health and Hospital refers to their model as integrated and aligned systems. We've got the rhetoric, we've got some financial incentives, we have some real possibilities, but I hope we don't set up little aligned islands that cannot communicate in a systems way across. Community mental health, absolutely critical. System under siege, system with resources every one of us needs. System that reacts wonderfully when you reach out to them. Even better if you look at cross-contracting with them for some services. And we can really get ourselves to integrated behavioral health within our health centers, within your free clinics, and within almost any health and human services site, if we reach out and we look at creative contracting. Academic resources I mentioned are many, many, many to be looked at. Pharmacy, services for health centers. Some of our health centers started their own. Many of our health centers contract with community-based pharmacies, and that is a tremendous relationship because the collegiality, especially in rural communities, of pharmacists as health professionals helps to build that team. Patient-centered, team-based, continuous, integrated, 24/7. Health centers have been a good model of that. They have much to learn, and I think they have much to learn from free clinics in terms of being able to reach out into communities. They need to align with you. They need to align with aging programs. They need to align with anyone, any organizational entity that can help patients, people in their home get what they need 24/7, anyone, anytime, any place. We've got all the pieces, we have assets, we have the science, we have the resources. Do we have the political will? And I think that is our greatest issue. So what I want to leave you with is population health is what we're looking for here. We're looking for public health, we're looking for medical care. Medical care is only 10% of that equation. 90% is social determinants, and we've all got a lot to learn about how to make those weave together to create systems. So let's try to align the incentives that are available to us through the accountable care, through ACA, whatever it is, health reform, and see if we can't move us to systems, answers in full population health, because I'm getting way too old to keep doing this work for a whole lot longer. So thank you to my friends and colleagues and all the amen things that they had to say.
Thank you, Kim. And yes, and Kim really did do a fabulous job of summing up the afternoon. And so with that, I am going to adjourn us. I think the speakers, other than Sarah, can stay for a little while for discussion. We do have a reception. I want to thank everyone for attending for this very provocative conversation. I would encourage us, as Kim said, we need to be aware change is needed. We need to plan for it now. We have a tremendous opportunity, and I think we have a great group of thinkers here that are all ready to commit to that change. And so that's where we hope that we're going to go from here.